Welcome to the presentation for Module 11, Nursing 150. This presentation will discuss, first of all, we'll kind of review the assessment of the nervous system, the important pieces, the key features of that assessment, and then we will move on to discuss TIA and stroke symptoms and nursing care associated with these disorders of the nervous system. So just a little bit of review of the nervous system. Make sure you just kind of go back and just kind of skim through your anatomy and physiology and your general functioning of the nervous system. Major divisions of the nervous system are the central nervous system and the peripheral nervous system. Central nervous system is composed of the brain and the spinal cord. The peripheral nervous system is just mainly referring to the periphery of the nervous system. It is composed of 12 pairs of cranial nerves, 31 pairs of spinal nerves, and the autonomic nervous system. The autonomic nervous system is further divided into the sympathetic and parasympathetic. We've talked about these nervous systems along the way and a lot about how medications are kind of affect these different types of nervous systems. The interesting thing to remember is that the endocrine system works together with the nervous system in fluid balance and electrolytes. The autonomic nervous system innervates many body systems, such as the reproductive and digestive organs, to promote their function. So there's lots of different things that your nervous system is involved in. The systems work together to control cognition, mobility, and sensory perception. Health problems with the nervous system can involve trauma and diseases of the nervous system that impair fluid and electrolyte balance, thermoregulation, elimination, and many other functions. One of the earliest and most sensitive functions that signal a new onset brain disorder is cognition. Cognition, make sure you understand the term cognition. Cognition refers to all of processes of human thought. Primary role of the nurse is to help restore human needs or assist the patient adapt to their deficit and avoid complications from these dysfunctions. So that's basically what our goal is in caring for these patients, and so that's what we're going to kind of keep in mind along the way. Speaking specifically about a neurological assessment, appearance. Remember, when you do your head-to-toe assessment, you are honestly constantly monitoring their neurological status. You know, as the patient walks in the room, do they have a steady gait? What's their affect? How's their movement? Is it symmetrical? Are they dizzy? Do they have slurred speech? As you begin to talk to them, you should always be on the lookout for monitoring for any cognitive deficits. Do they have trouble speaking? Do they have trouble hearing? Are they able to communicate with you? Are they able to carry on a conversation with you? Things like that. So you're constantly doing this neurological assessment, whether you even realize it or not. And you'll begin to get better as your experience continues in monitoring a patient, that you'll pick up on some of these cues quickly as soon as they walk in the room. It is important to know someone's baseline. If somebody has already some cognitive issues, then it's important to know that, to understand what their baseline is and determine if there's been any change. Family history, of course, is always a piece of your assessment. Being able to determine if a patient has any family history of any kind of neurological disorders. A lot of these disorders do tend to run in families. You also need to know the patient's medical history. Has there been a history of a stroke? Has there been a history of TIAs, things like that, and we'll talk about that further along. Moving on to a more focused neurological assessment. Make sure you have an understanding of what a neurocheck is. It's usually a rapid neurologic assessment completed when a patient is admitted to a healthcare facility on an emergent basis. It can also be part of an ongoing patient assessment and performed in the event of a sudden change in neurologic status. A neuro check is usually collecting data related to the patient's alertness, their orientation, their movement of arms and legs, pupil size, and reaction to light. So that's your PERLA, your orientation. Are they person, place, time, and situation? Are they awake? Are they stuporous? Are they lethargic? Things like that. The National Institute of Stroke Scale and the Glasgow Coma Scale are very focused neuro assessments typically associated with a patient who has experienced a stroke. The National Institute of Health Stroke Scale is commonly used assessment after a patient arrives into the ED after a suspected stroke. Glasgow Coma Scale is used to frequently monitor for changes in level of consciousness throughout the patient's care. Specific patient manifestations of stroke should be monitored during this time. So those two we'll talk about very specifically when we talk about stroke. The rest of the assessments here are part of a neurological assessment. Cranial nerve assessment usually includes looking at PERLA, looking at the pupil constriction, if it's equal, round, regular, and react to light and accommodate. Assessment of motor function is usually looking at their physical activity, observing them for involuntary tremors or movement, making sure that they have normal movement. Abnormal movement would include like pill rolling. That would mean having the thumbs and fingers rubbing together at rest, and tension tremors of both hands, and that means tremors that occur when the patient tries to do something. Strength is a piece of the motor function. Sensory assessment usually includes assessing the patient's ability to feel pain or light touch. The other piece of this is proprioception, which means the ability to be aware of their extremities. This type of assessment will come into effect, especially when you have a patient who has deficits associated with a stroke. Any patient who has had any abnormal symptoms, we'll talk about it more as like with MS or myasthenia gravis or ALS. And this is kind of the perception of pain, that sensory function. Some people have difficulty with pain perception, pain and temperature sensations, touch discrimination, which means that the ability to determine if something is either soft or sharp, things like that. Assessment of the cerebellar function includes coordination of muscle activity. Gait and equilibrium are assessed in this point. Usually tested when you ask the patient to walk across the room, turn and return. You observe them for uneven steps, difficulty walking, any kind of looks like they have some lack of balance. Sometimes having them to walk on their tiptoes and heel to toe can also help you be more specific about their gait. Another test that is done to check cerebellar function can be having the patient stand, close their eyes, and have them have their arms open, and just watching them with their eyes closed if they can maintain position. Do they sway? If they start to sway a little bit, it could mean that they have some problem with proprioceptive, which means awareness of body position. If the patient sways with the eyes both open and closed, the neurologic disturbance is probably a cerebellar in origin. We will continue to talk about these assessments as we go throughout Module 11. This is an example of the Glasgow Coma Scale. This is used in many areas to obtain and document a baseline data, neurologic data for a patient regarding eye-opening, motor response, and verbal response. It is used a lot because it's easy, it's short and easy to do. It just needs to be used appropriately. But typically, the lower the Glasgow Coma Scale, the more poor the outcome of the patient will be. and the worse shape your patient is in. So the lower the number, the lower the neurological functioning is happening. This is just kind of a reminder of the anatomy and physiology of the brain and the central nervous system. Your brain does have different lobes. Each lobe is responsible for a specific function of the body. For example, the frontal lobe is responsible for voluntary eye movement, judgment, ability to develop long-term goals, reasoning, concentration, the ability to remember past information or experiences. Parietal lobe is responsible for your three-dimensional sensation, taste impulses. The temporal lobe is the lobe that is the auditory center, complicated memory pattern, and the area of speech. So if you have someone that has a stroke or an aneurysm that affects their temporal lobe, that could affect their memory. It could also affect their sound, their ability to hear. Your occipital lobe is your primary visual center. So it's just important to kind of know that if we have something that occurs in some parts of the brain, it can affect your patient in different ways. It depends on what part of the brain is affected by either a stroke or an aneurysm or things like that. So your brain also has circulation. That's always important to remember. It needs blood supply, just like every other tissue in your body. This is just an example of how the blood flows. Remember that the blood is pumped from the left ventricle through the aorta. From the aorta, the blood is pumped through the carotid arteries that go up through the sides of your neck up to your brain. That is how your brain is supplied with oxygen and nutrients that it needs to survive and be healthy tissue. As we go throughout this presentation, we're going to talk about TIA and stroke. TIA means that there is a temporary blockage of blood flow to an area, and it causes temporary symptoms that are usually last less than 24 hours. I kind of associate that with a stable angina type circumstance of the brain. Stroke can be either ischemic or hemorrhagic. Ischemic means that there is a blockage in one of these cerebral vessels. A hemorrhagic stroke means that there is some kind of weakening in one of the walls of one of these vessels, and there is the bleeding out. And we'll talk about those a little bit more specifically, but it's a good idea just to remember that the brain is like every other part of the body. It needs a blood flow in order to survive and function. All right, so we're going to move into talking about a transient ischemic attack. This is a temporary neurologic dysfunction resulting from a brief interruption in cerebral blood flow. This is what I associate with maybe a stable angina. This is a stable angina of the brain. There could be some kind of a small blockage in one of the cerebral arteries that briefly disrupts blood flow and can cause some symptoms. The symptoms are typically short-lived. They usually resolve within 30 to 60 minutes. They can last up to 24 hours, but typically resolve very quickly. You have a chart in your book that goes over key features of a transient ischemic attack. It's a good idea to review those, the key features. Typically, your patient will exhibit visual deficits, which can be blurred vision, double vision, blindness or tunnel vision. Motor deficits, weakness in one side typically, facial droop. Ataxia, which is a gait disturbance. They could have numbness, vertigo, aphasia, or slurred speech. So these are key features, and again, they are short-lived, usually resolve within 30 to 60 minutes. The problem with TIAs is they are basically a warning sign for your patient that something is going on that is somehow briefly interrupting the blood flow. So it's important that the patient
identify this as a risk factor for a stroke and see and follow up with a healthcare provider in order to prevent it from becoming a stroke. The other thing about TIAs is they may damage the brain tissue with repeated insults. So single TIAs indicate a high stroke risk. Recurrent and multiple TIAs increase the risk for permanent brain damage. If a patient arrives to an emergency room with signs of a TIA, they most likely will be admitted due to the fact that they're at high risk for having a stroke. And so they admit them in order to implement measures to decrease risk factors for having a stroke. Risk factors include high blood pressure. The most common risk factor for stroke is high blood pressure. Taking aspirin or any antiplatelet drug such as clopidogrel or aspirin, that is keeps your platelets from sticking together. That would be a way to prevent an ischemic stroke. Controlling diabetes, keeping blood sugars in a range of typically around 100 to 180. Promoting lifestyle changes such as quitting smoking, eating healthy, and being more active. So this patient needs to leave the hospital if they're admitted. They will have some diagnostic tests done to make sure that the TIA was not an actual stroke. Testing for this would typically be a CT scan of the head. They also, what they're doing when they're doing a CT scan is ruling out a bleed within the brain, which would be a hemorrhagic stroke. That would require immediate transfer to a facility that could do interventions for a cerebral bleed. If these are negative, the patient will have further diagnostic testing, such as having their blood pressure checked, looking at their labs, looking at cholesterol levels, looking at blood sugar levels, making sure all of the risk factors are decreased for them to have a stroke before they go home. They'll also go home on lots of education regarding all the preventive mechanisms that they can put in place. Since they've had this warning sign of a TIA, we want to make sure that they do everything they can to prevent themselves from having a stroke, which could result in permanent deficits. They also need to be educated well on the signs and symptoms of a stroke, which we'll talk about in the next few slides, but they need to know when they need to call the doctor immediately if they experience any signs or symptoms of a stroke. This picture is just a visual way to show the difference in what the blockage within a cerebral artery could possibly look like in a TIA as opposed to a stroke. As you can see in this picture here, there is partial occlusion of the cerebral artery, and here with a stroke or infarction, there's a more of a complete thrombus occlusion within the cerebral artery. And that is an ischemic stroke that has two divisions. An ischemic stroke can be from an embolus or a thrombus. This one would be a thrombus. An embolus is a clot that travels from another area of the body to the brain. And we'll talk about those more specifically in the next few slides. It's a visual picture of what a stroke, or you can think of it as a brain attack. It just to kind of help you remember what it is, because it's very similar to a heart attack. It's basically a brain attack in the brain, very similar to what we see in occlusion of a coronary artery that leads to a heart attack. Same thing can occur in the cerebral arteries. You can have a blockage that occurs that obstructs blood flow to an area of the brain and can cause ischemia or necrosis. So ischemic stroke is also broken down. I have a slide that does this. It's also broken down into an embolic stroke or a thrombus. Hemorrhagic stroke, is basically a bleed within the within the brain. And this is due to some kind of cause that ruptures one of the vessels within the brain and causes bleeding into the brain. One thing that I just want to kind of review is the brain and the anatomy of it, the vault that the brain sits in. If you think about it, your brain sits in your cranium, your skull. The skull is meant to be very rigid. It does not stretch because it is made to protect the brain. It's made to be very hard and indestructible so that it protects the brain. If there is bleeding or swelling within that brain, bleeding can often lead to swelling within the brain. There's nowhere for this to go because your skull is essentially a vault that doesn't stretch under pressure or anything like that. So this can lead to what we call increased intracranial pressure, which will essentially lead to brain death. This increased pressure and swelling that can occur after a brain bleed, and that increased intracranial pressure can lead to a neurologic death, which we know is the term brain dead. So that's why this can be very, very detrimental, the hemorrhagic stroke, to a patient. And we'll talk about these more specifically, each one. This is just a good visual that explains the different types of strokes. Ischemic stroke has two causes. One is a thrombus, which means a clot within the cerebral artery that can be caused by things such as atherosclerosis. Thrombotic strokes do account for more than half of all strokes. They're commonly associated with the development of atherosclerosis, like I said. The process of an occlusion of a cerebral artery is very similar to that of a coronary artery. The rupture of one or more plaque promotes clot formation. When the clot is of sufficient size, it interrupts blood flow to the brain tissue, causing an ischemic stroke. An embolic stroke is caused by a thrombus that breaks off from another area of the body and travels to the cerebral arteries via the carotid, which is the carotid arteries are what come up your neck off of your aorta. The usual source of an emboli that causes an embolic stroke is the heart, a clot that is started in the heart, typically secondary to an atrial fibrillation, a heart valve disease, or after a myocardial infarction. Hemorrhagic stroke is the second major classification of stroke. In this type of a stroke, vessel integrity is interrupted and bleeding occurs into the brain tissue. Causes of a hemorrhagic stroke include hypertension. Elevated blood pressure leads to changes within the arterial wall that leave it likely to rupture. Damage to the brain occurs from bleeding, which causes edema, which causes displacement, and that's direct irritants to the brain tissue. So that's, like I said before, it's this edema within that vault, within that skull, that causes increased intracranial pressure, which causes brain damage. An aneurysm is an abnormal ballooning or blister along the normal artery. We talked about aneurysms that can occur within the aorta. It's the same thing. It's a weakened spot on the artery wall. These aneurysms can rupture and cause an intracranial bleed. Arteriovenous malformation is a common abnormality that occurs during embryonic development. So this is something that you can't prevent. It's just something that people are born with. It's a tangled collection of malformed, thin-walled, dilated vessels within a capillary network. There's a picture in your book of a arteriovenous malformation. Basically, it's just when a person is born, there is a malformation in the artery, the arteriovenous area, where the arteries meet the venous system. There's some bulging and some weakness in the arterial walls, which causes the patient to be at risk for a rupture, which causes bleeding into the intracranial tissues or spaces. This is, again, just explaining what an ischemic stroke is. This is an occlusion or blockage of a cerebral artery. Typical, the thrombus type is very similar to what causes a blockage of your coronary artery. It's atherosclerosis, which can lead to a breaking off, the plaque breaking, causing clotting to occur, which completely occludes the cerebral artery.
Once that occurs, there's an area of the brain that's deprived of oxygen and can become ischemic, which leads to necrosis. And this will cause signs and symptoms of a stroke, which we'll talk about in the next few slides. An embolic stroke is, again, it causes the same types of symptoms. However, it is just a clot that comes from another area of the body and travels to the cerebral system. One of the number one causes of an embolic stroke is atrial fib. And we talked about that a little bit before when we talked about the heart. Atrial fibrillation means that there is an area that is irritated within the atria, and it stimulates a fibrillation of the atria, which means that the blood does not flow through the atria into the ventricles like it should. So there's some blood kind of churning in there, and the more blood sits stagnant, it can clot. So those clots form, and they can be, when they come off of the aorta, they could go to the carotid artery and block blood flow to the brain. There are risk factors that cause atherosclerosis or blockage of one of the cerebral arteries. Risk factors for stroke are put into three categories. The risk factors that cannot be changed, which are non-modifiable, risk factors that can be changed with medical treatment, and risk factors that can be changed with lifestyle modification. People that have a family history of the arteriovenous malformation, that is something that a risk factor that cannot be changed. Sometimes a family history of an aneurysm is something that cannot be changed. If someone has a medical condition that causes them to have hypertension, we talked about that. Those are those secondary hypertension people with renal failure, people with Cushing's disease. They could possibly have hypertension that could be a risk factor for stroke. So they need to have those conditions treated in order to treat their hypertension and end the process decreasing their risk for stroke. People with predisposing health conditions should be aware that lifestyle habits contribute to stroke. Basically, hypertension is one of the big things. They got to make sure that they get their hypertension identified and treated, and that they're compliant with their treatment for hypertension, or it could lead to risk factors for stroke. And the same things for coronary artery disease. Lifestyle modifications should be applied also to decreasing the risk of cerebral vascular disease. It's that diet, high fiber, low fat, light to moderate alcohol consumption, making sure that they have an active lifestyle, that they're getting adequate exercise. There are some, going back to those non-modifiable risk factors, there's some cultural things that we know that put a patient more at risk for stroke, and not necessarily cultural, but ethnicity. It seems that African American men and women have more strokes than Caucasian. American Indian and Alaskan Native groups have the highest prevalence of stroke, which is interesting. About half of the excess stroke risk in blacks between ages 45 and 65 years is attributable to traditional risk factors such as elevated systolic blood pressure and socioeconomic factors. And I think Patty talked about this in her lecture about how there seems to be that we're finding cultural and ethnicity together are risk factors. So culturally, if you look at the interesting thing about American Indians also have a high incidence of alcoholism. So are they having more strokes because of the alcoholism, or are they having more strokes due to their DNA as having the ethnicity of an American Indian? So again, it could be both. It could be a little bit of both. And just kind of like what Patty was saying, I think we're going to see that we're going to further find that ethnicity and cultural things collide in making a patient more at risk for some disease processes, which is just kind of interesting.
This is a good picture showing how atrial fibrillation makes a patient at risk for an embolic stroke. So this is those atria fibrillating right here. And here, see how those arteries come off the aorta here? And that clot that is created in the atria with atrial fibrillation can be directly put into the carotid arteries and go straight to the brain. So I just think it's a good picture to help you grasp the idea that one of the number one reasons a patient has an embolic stroke is due to atrial fibrillation. In relation to that, you will find that a patient diagnosed with chronic atrial fibrillation will be prophylactically treated, typically with warfarin. They're starting to give people some of the different types of anticoagulants, but traditionally it's been warfarin. They'll give them a kind of a low dose warfarin to keep their blood thin, so that if they have a chronic atrial fib, hopefully the blood will not clot, and then in turn they can prevent as an embolic stroke. Okay, looking more specifically at hemorrhagic stroke. Hemorrhagic stroke has several different causes. They all lead to some type of bleeding within the brain tissue, which leads to edema in the brain. It's irritating to the brain, so you're going to see cognitive changes and signs and symptoms of a stroke within your patient. Intracerebral hemorrhage is typically associated with hypertension or sustained hypertension, which means hypertension that's not controlled. The elevated blood pressure leads to changes within the arterial wall, which will create possibly a rupture. And this is the intracerebral hemorrhage that occurs after the rupture. A subarachnoid hemorrhage is essentially talking about where in the brain the hemorrhage occurs, and it's talking about the subarachnoid space, which is the space between the pia mater and the arachnoid layers of the meninges covering the brain. This is caused by a ruptured aneurysm or arteriovenous malformation. That's usually where that occurs. Can also be caused by trauma. An aneurysm is an abnormal ballooning or blister. We talked about aneurysms in the last module, about how they are a weakening in the vessel wall that can rupture. Vasospasm is just where there's a spasming of the cerebral arteries, and it can be associated with lots of different things. A lot of times it's due to a rupture, an aneurysm rupture, and then blood flow to the distal areas of the brain supplied by the damaged cerebral vessel is markedly diminished, and then reduced perfusion from vasospasm contributes to secondary cerebral ischemia. Here's some pictures of what an aneurysm may look like within the cerebral arteries. And so you can see this would be kind of I believe a fusiform or a berry type aneurysm off of a arterial vessel, and then this is what it would appear as it ruptures due to the high pressures in that area. Okay, moving on to taking care of a patient with signs and symptoms of a stroke. We've talked about the reasons why someone might have a stroke, so let's talk about what they would present as. And we know this in every situation. An accurate history is important. It is excessively important in a patient who presents with a possible stroke. The reason why is treatment very much depends on when the onset of symptoms occurred. So an accurate history is really, really, really even more important in this situation. The information, like I said, can assist in identifying the area of the brain involved as well as the cause. So, big question, big question. When did the symptoms begin? We have to know that if at all possible. That helps our treatment. And then again, some assessments is a list of current medications. And the reason we need this also guides our treatment. If we have somebody who's on anticoagulants, if we have somebody who has atrial fib, that kind of helps us kind of determine exactly what's going on.
And then there's that NIH stroke scale. That scale can be found in your book. And it's basically giving them numbers for level of consciousness, following commands, their visual, facial palsy. Again, we like numbers, if you recall that I've said this in the past. In healthcare, it's helpful to us to have numbers to score someone. That way, it helps us to determine if a change occurs. It helps us determine a baseline and then when change occurs. Instead of just, I don't know, maybe it's a little different. We have numbers that tell us specific things. It's a very measurable, specific way to monitor a patient. So make sure you look at that NIH stroke scale, because you may see that again in practice for sure if you're taking care of patients who may present with symptoms of a stroke. Okay, so monitoring a patient's cognitive, motor, and sensory changes is helpful to us to look for stroke symptoms. Stroke symptoms can appear any time of day or night. The 5 most common symptoms are sudden confusion or trouble speaking or understanding others, sudden numbness or weakness of the face, arm, or leg, sudden trouble seeing in one or both eyes, sudden dizziness, trouble walking or loss of balance or coordination, a severe headache with no known cause, a sudden severe headache with no known cause. Those are the 5 most common symptoms, according to the CDC, that a patient presents with. And these are all fall under the range of cognitive changes, motor changes, and sensory changes that can occur. It's typically, you guys have all seen it. You can look on the American Heart Association website for all of those signs and symptoms. There's an acronym. It's called FAST, which stands for face. And it's, oh gosh, I can't make enough here. Face. And that's referring to that facial change, which could mean a numbness or weakness of the face. And it's usually one-sided. The A stands for arm weakness specifically, so that's that more of those motor changes. Typically, if it is unilateral, that is indicative of a possible stroke. S is for speech, so speech difficulties. That's some of that motor change as well. So if they're having slurred speech, difficulty getting words out, difficulty understanding a person, those are things that are indicative that a patient is having a stroke. And then the last but not least is time. Again, going back to that question that I told you is most important with a patient who has had a stroke, who presents with stroke symptoms, time. When did it occur? We need to know when it started. And we'll talk about the treatment for an embolic stroke. Is very much guided by when the symptoms started. So the one thing that I want you to understand is a CT scan without contrast is standard for initial diagnosis. Absolute standard. If someone comes into an emergency area complaining of left-sided weakness, a left facial droop, they're having difficulty with their speech, the first thing we're going to do, well, let's talk about this, the first thing, really. Patient comes in, we're always going to get vital signs. We're going to ask that question, when did your symptoms start? And remember, we always check airway, breathing, circulation. Okay, vital signs are okay. They're breathing. They have an airway, and they have good circulation. Now we're going to go to CT scan. The reason we go to CT scan is because we need to find out is it a hemorrhagic stroke or is it an embolic an ischemic stroke. The CT scan will tell us if there's any bleeding. So essentially, the major reason why we go to CT scan is to rule out a bleed. Because the difference between treating a patient with an ischemic stroke and a hemorrhagic stroke is enormous. Can you imagine? We either have a clot or we have a bleed. So we have to figure out which one, because they can present the same. A patient with a bleed that's causing edema in their brain can present with a lot of these same changes. And so we always, always, always have to make sure that they're not bleeding. So we rule out a bleed. We don't always see an ischemic stroke initially on a CT scan, but we can certainly see if there's a bleed, so we do it to rule out the bleed. This is a visual picture. It actually comes straight from your book. It talks about the sensory changes that occur after, in a patient who has experienced a stroke. The sensory exam evaluates the patient's response to touch and painful stimuli. The one thing to always be aware of is that your spinal cord, as it comes up and reaches the brainstem, it actually crosses over. So the nerves that innervate the right side of your body are actually found in the left side of your brain. The nerves that innervate the left side of your body are found on the right side. So it's important to remember that they do cross. So if someone has a boo-boo in their right cerebral hemisphere, they will experience deficits on the left side of their body. So a right side brain boo-boo affects the left side extremities. So they're going to have their left side is going to be affected. They might have left paralysis. This picture here is showing if some damage occurs somewhere around the optic nerve. There can be some visual disturbances. One to note is something called homonymous hemaniopia, which is a fun word to say, if nothing else. But it can cause blindness in the same side of both eyes. So that's what this is kind of trying to depict here, is that it's a weird visual change for the patient, homonymous hemaniopia. I want to make sure that you kind of look through your book. There's some terms that you want to make sure that you understand. Nystagmus is a term that is typically related to a neurological assessment. Nystagmus is when it's usually associated with the nerves that that control the eye movement. So nystagmus is that kind of shakiness of the eye. So if you have your patient follow your pen light and you have them look to the side and they get kind of a shakiness in their eye, that's involuntary eye movements essentially is what nystagmus means. Some other terms are dysphagia, making sure that's a patient who has difficulty chewing or swallowing food. Apraxia, which is difficulty carrying out speech. Lots of different terms kind of in your book related to deficits that can occur associated with a stroke. So make sure you kind of review all that. Okay, major thing with a hemorrhagic stroke or a ischemic stroke is that hopefully we are either transporting them to a stroke center or we are collaborating with professionals from a stroke center. So for instance, the Cincinnati area has been leaders in stroke care. University of Cincinnati created something called the stroke team, which others around the country actually learned from and mimicked due to how successful it was. So what occurs in Cincinnati is if a patient comes to the Christ Hospital, just for example, with symptoms of a stroke, we CT scan them. We say, yep, they do not have a head bleed. It appears that they possibly have an ischemic stroke. So we call UC and we say we have an ischemic stroke patient here. And they either send out a representative or they will coordinate care via our technology. We might put a camera on them so that they can monitor them and treat them that way. some kind of telehealth way. So it's really interesting and it's really effective. Basically what we're doing is we're calling in experts and we're saying we need help. We have a patient who has a stroke. We need your guidance in order to treat this patient, because studies show, and if you look on the American Heart Association, studies show that if we identify a stroke, we treat it quickly, these patients can walk out of the hospital with nearly no deficits if we get it treated appropriately. Because years ago we were, not treating at all. We weren't understanding it. We weren't getting treatment, things like that. And we weren't getting treatment in a timely manner, and people were walking out, we're not walking out. That was the problem. So identifying whether a patient has an ischemic stroke, and then in a time frame. If we can establish a time frame and we can establish that a patient meets criteria for thrombolytic therapy, which is those medications that we talked about in the past in module 9 and 10, those clot busters, we can actually administer this thrombolytic therapy and hopefully bust up that clot that has occurred within that patient's cerebral artery, and we can restore blood flow to that brain in a timely manner, and the patient can recover. Try to relate this back to when we were talking about time is muscle, when we were talking about the heart. Basically now time is brain function. So we need to know a time frame, and we can treat it. If we can treat it quickly, then we can actually reverse, not necessarily reverse, but the sooner that we get the blood flow back to that organ, the better off the patient is going to be. All right, so let's talk a little bit more specifically about thrombolytic therapy. Thrombolytic therapy for an acute ischemic stroke should dissolve the cerebral artery occlusion and reestablish blood flow and prevent a cerebral infarction. And remember, infarction means that the area has been absolutely deprived of oxygen and now has injury. So that's why time again is of essence in a patient with stroke. That's why we're trying to educate the public about the signs and symptoms of a stroke, so that they can get their loved one into an emergency department and get them treated in a timely manner, so that we can reverse any kind of blood flow occlusion that has occurred and regain blood flow to the area. So talking about thrombolytic therapy, you've heard the term alteplase. That's the only drug approved at this point for treatment of acute ischemic stroke. It is a fibrillation that activates plasminogen to degrade the thrombus. All right, so basically our biggest question as soon as they come in with a right-sided weakness, right-sided facial droop, difficulty speak, we want to say, when did the symptoms start? Because we can only administer thrombolytic therapy within 3 to 4.5 hours of onset of symptoms. So we have to establish a timeline, and then we also have to determine, when the onset of symptoms started. If it's been within 3 to 4 hours, that patient is a candidate for thrombolytic therapy. If we don't know, that's a problem. A lot of times patients may present and maybe they're confused and nobody knows, and the patient can't tell us when the symptoms started. That is when we definitely rely on the stroke team for their expertise to determine whether we should do it. A lot of times they will not do it if we don't know when it started. There are some other contraindications for thrombolytic therapy. Again, it's if a patient has a history of a stroke in the past or diabetes. If the patient has a baseline National Institute of Health stroke scale of greater than 25. If the patient is already on an anticoagulant, so basically their blood's already thin, it's a little risky to give them a thrombolytic. So there are some contraindications. The list of contraindications is getting a little bit smaller. But we do have to be somewhat careful in this eligibility criteria. In the event that someone does receive thrombolytic therapy, there is specific nursing care that we need to make sure that we are implementing. Basically, we just got to monitor them, make sure that they don't have a bleed. And the interesting thing with a patient with an ischemic stroke, that means they have a clot within their cerebral artery, and we administer thrombolytic therapy. We have to watch them so close because they're at risk for, because sometimes that clot in their cerebral artery could actually weaken the vessel wall. And remember, if it's an atherosclerosis in there that's causing, and the plaque breaks off and we have a clot that forms, that all could have injured the integrity of the vessel wall, and then we give them a thrombolytic that breaks up all their clots, that person's at risk for bleeding. So you have to monitor them for signs of a head bleed, which means any signs of increased intracranial pressure. Typically, one of the first signs of an increase in their intracranial pressure is a change in their mental status. And remember, we've talked about this before. Any patient who presents with a change in their mental status, their level of consciousness, you need to call somebody, and you also need to do a very focused assessment to determine what just happened. Because typically it's some kind of a neurologic episode that has occurred. Perhaps, especially in this patient, it could be a intracerebral bleed. I want to draw your attention, in your book, there are several nursing safety priority alerts on the page that talks about thrombolytic therapy. And that's because, again, it's a great treatment. It's a great therapy when it works. There are some contraindications, and there are very specific things that we need to do as nurses to monitor these patients that are treated with thrombolytic therapy to make sure that they don't have complications associated with it. One of the big tables that you have in your book is called Nursing Interventions During and After Administration of Alteplase. So make sure you kind of review that. Those are some very specific things that you need to know. There is also a table in your book that is key features of increased intracranial pressure. I suggest that you kind of look that over and be familiar with some of those. Again, the first thing on the list is decreased level of consciousness or lethargy, behavior changes, headache, nausea and vomiting, change in sensorimotor status, seizures, abnormal posturing. There's something called Cushing's triad. Cushing's triad is one of those things, we like to kind of have fun little acronyms and things like that. Cushing's triad are, if these three things exist, your patient is showing signs and symptoms of increased intracranial pressure. So the first thing is increased blood pressure, severe hypertension, a widened pulse pressure. So that means the difference between their systolic and diastolic blood pressure is widening. Sorry, my handwriting here. And then a low heart rate. So bradycardia. Those three things together indicate a patient those are Cushing's triad, and those indicate signs and symptoms of increased intracranial pressure that are usually associated with a head bleed. All right, treatment post-stroke. Thrombolytics we've already talked about. A patient who's had an ischemic stroke is going to go home on some kind of anticoagulant. It could be warfarin, especially if it's established that they have atrial fib and they possibly had an embolic stroke. They're going to go home on warfarin. Lorazepam, other anti-epileptics. We're going to talk about seizures, so hopefully that'll help you understand the lorazepam and anti-epileptics. Anybody who's had some kind of a brain injury is at risk for seizure activity, so we have to make sure that we treat that if that is necessary. Calcium channel blockers, that's for those patients who have hypertension. We have to keep their blood pressure under control to decrease the incidence that they would have any further stroke. Remember, calcium channel blockers vasodilate a little bit. They help to increase perfusion to an area, so that's why these would be appropriate drugs. Just reviewing, calcium channel blockers, nifedipine, diltiazem, amlodipine. So kind of make sure you remember the names of some of those calcium channel blockers. Stool softeners. This is an interesting thing. Stool softeners are often prescribed for patients who have had a stroke or who have high blood pressure. We don't want a patient to strain while they're having a bowel movement, because what straining does during a bowel movement is increase your intracranial pressure. So that's why they'll often be put on stool softeners. Analgesics for pain, of course. Pain causes increased blood pressure. It also can cause increased intracranial pressure. We want to take care of that brain now. It's been injured a little bit. We don't want to stress it. We want to make sure it's nicely restful. That is, again, the purpose for the anti-anxiety drugs. Anxiety makes your blood pressure go up, leads to other major issues such as possible stroke. So that's why these drugs would be appropriate for that. Okay, looking for complications. Hydrocephalus means increased fluid on the brain. Again, increased fluid in that vault causes edema. It causes decreased functioning of that brain because it's under pressure now. Vasospasms of the cerebral arteries can happen due to just the irritation that's occurring within the brain. And we know that vasospasm can lead to a decreased blood flow to an area, so we want to prevent that. The calcium channel blockers are actually good drugs to prevent vasospasms. Anybody who has had some kind of an injury to their cerebral arteries can be at risk for bleeding or rupture. So it's important for us to monitor for that. And think about what that would look like. Perhaps we have a patient who came in with what looked to be an ischemic stroke. They came in within that 3-hour window. We treated them with thrombolytics. The next day, they're doing great. Very little deficits associated with their stroke. And then maybe the evening after that, they suddenly have a change in level of consciousness. They become lethargic. That is indicative that they possibly had a rupture or a bleed, a secondary to the injury that occurred. So major nursing care associated with a patient who has experienced a stroke. Essentially, monitoring again for any signs of increased intracranial pressure. Safety. Safety because the patient could have some kind of a deficit, sensory motor, lots of different types of deficits, maybe some kind of weakness on one side. One thing to make sure you're on the lookout for is something called unilateral neglect. Means neglect syndrome. It occurs most commonly in patients who have had a right cerebral stroke. The problem places the patient at additional risk for injury because basically what it is they're unaware. They completely become unaware of that other side of their body. So it actually, like, they can kind of flop their left arm around. So if they've had that right hemisphere stroke, their left side is weak. And so when they get up and get down, they forget that they even have a left side, so they'll kind of bang it around. So that puts them at risk for injury. So lots of different, basically safety is a huge thing. They're at more risk for falls because they have some kind of a weakness on one side. They could have unilateral neglect, decreased mobility. Decreased ability to communicate puts them at risk for safety issues. And then there's all that emotional support because now they are someone who possibly was a very functioning individual who has now had a stroke and is now unable to communicate, unable to carry out their activities of daily living. So emotional support is very important in those situations. Education. We could go on and on about the education. The education is associated with now possibly devices to help them with their mobility issues. It's education possibly about new communication techniques. They might have to relearn
and go to physical therapy. Part of education should also include any kind of post-stroke depression. Some patients who have now had a major change in their life can experience some depression, so that's important to make sure we educate about and educate the patient and their family that they should report any kind of concerns regarding this and that we can help them find support groups and maybe some medication to treat that if needed. The teaching plan includes lifestyle changes, drug therapy, ambulation transfer skills, communication skills, safety precautions, nutritional management, activity levels, and self-management skills. So lots of education post-stroke for patients who possibly have now have deficits that they have to deal with and possibly need to that's their new normal, so they have to kind of manage. So we've already kind of talked about this, the nursing diagnosis in the last few slides, and it's basically talking about mobility, promoting self-care, communication deficits, continence could suddenly become an issue with some patients who've had a stroke. So skin integrity, managing changes in sensory perception can be a problem. So think about interventions as far as safety, basically educating a patient about new devices that they need to use, making sure they have some kind of way to call for help if needed, thinking about communication, making sure they have physical therapy, speech therapy, providing them with alternative means of communication, making sure the call light is in reach. Lots of different interventions associated with this, making sure they have support groups, making sure they have support at home, possibly sending them to rehab if they don't have anyone at home that can help them. Discharge teaching is a lot about their medications. If now they are on an anticoagulant, they need to understand that they need to report signs and symptoms of increased bleeding. We know what those are now. Increased gum, if their gums are bleeding, if they have black tarry stools, things like that. Key features of self-management, education for a post-stroke patient. I kind of talked about that in the last slide. A lot of it is associated with talking to the patient and their family about disease prevention, disease-specific information, and self-management. Refer them to American Heart Association so that they have a website to look for information. The teaching plan typically includes lifestyle changes, drug therapy, which usually is about maybe antihypertensive medications, anticoagulants, maybe anti-anxiety medication. Talking to them about communication, ambulation skills, safety, always nutritional management, which we know is about low salt, low fat, high fiber, good amount of vegetables, low fat meats, things like that. Return demonstrations are very helpful for the nurse to determine the family member's comprehension of what we have taught them. Referring them to PTOT and speech therapy is of high priority, of course, in a patient who has these deficits. This concludes the presentation for Module 11, Nursing 150, regarding TIA and stroke. I look forward to discussing this information with you in class. The next few slides go through some questions and case studies related to these disorders.